Welcome to CareTalk, America's home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrics. David, we have a special guest today. We have the president of the United States of Care, my friend, Natalie Davis. And the U.S. of Care is focused on building a better healthcare system. And since we all know that it kind of sucks right now, she's going to explain what we're doing, what we all should be doing about it, and what the U.S. of Care in specific is doing about it. Welcome, Natalie.
Great. Thank you so much for having me.
You know what? I think it just shows how important healthcare is. You know, not only do we have a United States of America, but we have a United States of Care to go along with it. I think that is just terrific, John, and really shows how important it is.
Well, I think that they're actually, while you're poking fun at it, I think one of the biggest challenges we have, Natalie, maybe you start here, is getting people to agree on what some of the problems are and kind of coming up with common solutions in this uber politicized time. Why does a united approach to the United States of Care really matter?
Yeah, thank you. And thank you for the question, and actually tees me up perfectly to talk about what we do at United States of Care. When we launched 5 years ago, we really set out to find a path of where do people across this country, across demographics, agree where the healthcare system is working for them and where it doesn't. We looked around when we launched this organization. It was right on the heels of the summer of repeal and replace. And we said there needs to be an organization that is thinking about the future of our healthcare system, but really with the idea of understanding what works for people and what doesn't, and finding those united needs and united experiences. So we spent years doing that, going across the country and talking to people. I started out at a kitchen table in San Diego, to the streets of Philadelphia, then moved to Zoom during the pandemic, focus groups and national polls to really understand what is working and what isn't. And I can tell you the future of the healthcare system, when you talk to people, it needs to be affordable, dependable, personalized, and easy to navigate. And the four goals that really resonate with people are aligned there. They have the certainty they can afford their healthcare. Their coverage is there when their life changes and they can depend on it. That the healthcare system provides personalized care when and how they need it. And the healthcare system is easy to understand and navigate, which might be the hardest one to tackle. But those really resonate across. Yeah.
But we have these standards. I mean, I think maybe to frame it for a moment, over the last, since the Obamacare got passed, being pro or against care in general has been a lightning rod issue for politics and has divided even those who might agree on different policy decisions. You're now talking about people agreeing on policy as well as approach to healthcare. How the heck is that going?
It's going well, and it's frustrating because there are things that we need to fix on this healthcare system, but we have seen progress towards these four goals, and we took these four goals and found the 12 solution areas, the 12 specific areas that people want us to focus on. And some of the ones that we've seen progress on were just recently out of Congress with reducing prescription drugs. That was the number one issue people wanted us to work on, to making sure people could afford their health insurance. We saw the tax credits pass, and people will have those benefits of making sure they can afford their insurance. Over the last 3 years, we've passed legislation in 3 states to make sure more people have more coverage that they can afford, and continue to see progress at the state and federal level. But there's so much more to do. People cannot afford their health care. It's the number one issue that we hear. Even when you talk about caregiving, maternal health, or others, it comes down to affordability. And so there's a lot of room for progress.
So, Natalie, I'm trying to understand, why it's important to go on this sort of, listening tour. We have a lot of experts around. You have Mr. Driscoll among others. Why is it important to go and listen to the people as opposed to listen to the Driscolls?
Well, when we started the organization, we brought in people like John and Lauren and Senator Frist, Andy Slavitt, Mario Molina, Dr. Rhonda Meadows, people, luminaries across healthcare, to say, come with us on this journey, help us be a part of the solution, but let's base it on what people need. Because often when you do talk to politicians or to others, there is a belief that people don't agree, that the American people want different things. And while that's true, there are things that people want help on. The one that interested me the most, and we're diving into in our Policy Innovation Lab, is a real desire for caregivers, for people to have support when they care for loved ones at home. It's actually the number one issue that spiked for Republicans. And as a political organization, you look for where you find these spikes across political demographics. And that tells me that we have issues that aren't politicized yet. That tells me that if we can base these on human needs, human stories, and work with people across the aisle, or bring smart solutions that the general public agrees on, that we can have some space to work with leaders in the healthcare system to push these forward with policymakers.
But Natalie, one of the things that's attractive about the United States of Care is that you've got folks like Senator Frist, who was the Republican majority leader, and you've got folks like Mike Leavitt, who worked as President Bush's Secretary of HHS, and you've also got Andy and others who worked in the Obama administration. But what's frustrating is that even in the current environment where people agree, they sometimes posture to disagree. How do you solve for that around, because when you're talking about caregiving or prescription drug prices, those are all American issues. So how do you break through the clutter there?
John, it's some pretty dark stuff. It's like you say, okay, it's great that people agree, and then they decide to disagree despite the fact they agree. What are you talking about?
Well, David, we got to get you out of your COVID hiding spot up in the attic.
No kidding.
That you've been there for 2 years. The news ain't great, dude. There's a fair amount of divide and destroy. That's just, I think, part of the conventional politics of the moment. But what Natalie's raising, which is both intriguing and frustrating, is both that Biden just passed the first material drug pricing reduction since Part D is the way I look at it, Natalie, that it's a genuine benefit to people. And this is something that both Bernie Sanders and Donald Trump agreed on, and somehow they didn't get together on. So, David, actually, division's kind of an issue. So maybe we'll let Natalie answer it while you sit there in your ivy-towered attic in the People's Republic of Massachusetts.
I would say that one of my goals as the organization is that we are at the table when industry is at the table talking to policymakers, that the people's voice is right there, if not louder than that of industry. And I think we have the data to back it up on what people need. We have the data of where disparities are occurring, where people are unnecessarily dying or could be treated better based on their race, their class, their language. And so, I am optimistic, though I know it's an uphill battle, where we can be there. We can say this is what matters to people. We were just in rural South Carolina talking to people about their needs. We brought policymakers to the table in this library where we brought community members to talk about what they need. And amplifying people's voices that are already loud, but we can make them louder, bring those to other states, bring those up to the federal government, and be at the table.
Natalie, I just want to double click on what you're saying, because you've really, as David said, invested in going to what are people's authentic experiences outside of the Beltway conversation that's often way too complicated and no one follows it. So it becomes a to and fro between personalities. How do you take that, how to talk about the language of healthcare burdens and opportunities, and turn that into policy in a way that people even listen to?
Yeah. So one of the most interesting learnings that I've had over the years of talking to people is I would talk to them on the phone and I'd say, thank you so much for spending time with me. And they would say, I'm happy to talk to you, Natalie, about my experiences, but they're mine alone. Nobody else goes through the healthcare system because I'm either too smart or too dumb. I'm either too rich or too poor. I'm too healthy or not healthy. So really this experience I have, I'll tell you about it, but it's mine. And there are times where that's true. But it's actually also, I then heard the same stories over and over again of people feeling like their doctors weren't looking at their whole body. They weren't looking at their head, and their mental health is the same as their physical health, that they,
in many cases, they don't make eye contact.
They do make eye contact. People talk about that they can't believe their insurance is going to be there if they do get cancer, they get laid off during a pandemic. Their insurance is not there, and so we use words very, very intentionally. So our first goal, like I said, is people have the certainty they can afford their healthcare. We could have just said people afforded it, but when you get to the emotional discussions of people, it's that certainty is what they don't have, and it's what they need, and it's what's hampering them from getting care. So when we talk to policymakers or we talk to other people who are thought leaders in healthcare, we say, let's use words that really resonate with people. Value-based care, don't use that. Nobody knows what you're talking about, but you're talking about an experience where people are seen as their full body, where they're going and they have the support they need from other providers. We talk about targeted changes because when you talk to people, as much as they hate the healthcare system, they've got it taped up and all their little hacks that they've done to get through the healthcare system, and they're really afraid if you do a lot they can't get through this healthcare system, and they don't trust you can pull it off.
Natalie, you just screwed up a lot of Dave's business by saying that no one understands value-based care. He's been supping at that table for many years. Come on,
now, John,
Dave.
I was going to
you're on your back on that one.
What do you think about it, David? Yeah.
Well, I was going to say I do live in an ivory tower, but it's a synthetic ivory, so I don't want anybody getting too upset with me about it. And I think, value-based care, I think people like the word, value. But I had a question which relates to the kind of the role of the states versus the federal government. I usually expect a national organization to be focused on things at the federal level, but it sounds like you've got a mix of state and federal. How do those go together?
Yeah, so let me tell you about how we do our work. We go across the country and talk to people. I've covered that. We then have come out with United Solutions for Care. It's our agenda for change. It is these 4 goals and the 12 solutions that across demographics people believe will make a difference in their healthcare system. It's backed with evidence that these are issues, if we address in the right way, we can increase, make a more equitable healthcare system. We then run state and federal campaigns to drive these issues where we see opportunities, where there are leaders happening in states or with the federal government or with Congress. For us, we believe that any lever we can work on is really important. And more so when we started the organization, we said, let's have these state trials. Let's try things in different states. We've passed public option in 3 states. Each of those look different because each state is different. If eventually there's a place where we can go to the federal government and there's a president or another person who wants to run or really think about public option as an issue, we can point to different states that have built it differently, have implemented differently, and have different outcomes. So for us, it was very intentional as an organization to do that. Lastly, I'll say we also have a policy innovation lab where we know that this country doesn't have the right answer on everything, or we don't have good enough policy or policy with equity lens baked into it. And so we have an innovation lab where we work with people across the healthcare system to build new policy, which we can then deploy either through the private sector partners that we have or at the state or federal level.
So, your 4th goal about making an understandable system, and John, this gets to your nasty point about people not understanding value-based care. You do have 2 solutions related to making the system more understandable. One's about making prescription costs more transparent, and the other one is about increasing availability of patient navigators. Now, the navigators, John can explain value-based care, I suppose. But what are these 2 things for, and do you get some juice out of them?
Yeah. So what's really interesting about the first one is that we had these 4 goals we heard from listening to people. We brought over 70 different policies back out to people and said, we heard your goals. Do any of these resonate? The 12 are on our United Solutions for Care. People ranked, even if you can't change prescription costs, just tell me how much they're going to cost. Just tell me. And even if you don't change them, I can't afford it, but at least I'll know. And so we see a real need there. And I think we're going to need to bring that to the lab and understand how do we do that? Because I know it's not easy, but people want to know what the prescriptions are going to cost. And number 2, I wanted to call it a healthcare buddy, because when I talk to people, especially this one group in California, there was a woman who's a wheelchair user, and she talked about how hard it was for her to go and get a mammogram if she didn't have a loved one with her to help her lift her up, get her in the machine, and then listen to the doctor afterwards about what the outcome was. And everybody around the table kind of nodded and we're thinking, oh, when I've had this issue, I wish someone was there to take notes for me or whatever it is. And so, I was like, what if we had a healthcare buddy? And people were like, yes, like someone to come with me if a loved one can't. the word buddy didn't stick when we talked to others about it, but it really is this idea of someone to help navigate
It's a little
the healthcare
weird.
system. What's weird?
It's a little weird. The whole buddies, and like, it just reminds me way too
the
much
term didn't work.
of like nursery school and making sure you don't lose people going out to the school.
So it didn't stick.
But I think that there's but what does it say about our system that, without Sacagawea, that was the right reference, right? Right for the Lewis and Clark expedition there, David, to test your knowledge of America without a true guide. That you can't get the basics. I think is that the right question, Natalie? Or should we say, how about we design a system that doesn't require, expert supervision? I think that would be, I was with you on drug cost transparency, and David, you're going to have to move away from value-based bloviation to actually maybe work on it. Because I think that's something that everybody agrees on. Like, why can't you just tell me what I owe and just don't surprise me? I mean, I that talk about a bipartisan issue. Can we maybe double click on that and maybe come back to our need for supervised help? Because
John,
on drugs, it's critical. Yeah, David, come on,
John,
jump in here.
Yeah. I think a real simple way, if you want to simplify, people don't like all this sort of specifics. If you just say, this is your copay and does it have a comma in it or not? That's how you should say it. That would be my way to simplify it.
It is, but it really, drugs are not that hard. I mean, it is, you typically, that's something that I really do think, it typically doesn't affect as much the accumulators and all the other puts and takes. Mm-hmm. But given how important drugs are, they're increasingly the largest spend item for commercially insured. They're getting there on Medicare if you add it all up. That I do think that that if we could just get that innovation in place, I think my 88-year-old mom would really like to know what she owes and how it ties to what she's getting. It's a total black box system. I don't know what do you think about? Can we make progress on that one, Natalie?
I hope so. I mean, it's a big industry to go up against for sure. And when we talk to people, it's like, how can you just even tell us how we set the prices? Like, I'd love to know how much I'm going to cost, but also, like you just said, John, the word black box. How are these set? Why do they increase? I think it'll be really interesting with the implementation of the prescription drug through the Medicare program, and we will have a peek more into how they're being set or how Medicare is negotiating for these prices. And we're going to continue to be at the table to say these need to extend past Medicare. We need all people to make sure they can afford their insulin and other drugs. And so, I think there's going to be a big step forward towards this one of really making it clear how we're negotiating the price that the government will pay, or Medicare beneficiaries that will pay for their drugs.
When we think about these,
go, David.
If you think about these dozen solutions, your second one is about eliminating out-of-pocket costs for basic healthcare services. And on the one hand, we talk about bipartisan. That also sounds like, if you pitch it a certain way, it's like free stuff. It sounds like socialism.
So our country made a huge step, and I know you guys just had an issue on a session
episode,
on this episode about preventive services that people can get without paying out of pocket. There is a court case that could take that away for millions of people, especially on the employer-sponsored coverage. If it goes, if the decisions goes in a certain way and the ramifications go a certain way. So I think first we need to shore up and make sure that the out-of-pocket costs that people are shielded from through the ACA stay. But I think there's also some real desire from people where they can have more mental health care and preventive care that isn't out of pocket. And so we have a real interest in working with states, especially. We see some progress possible in the next couple of years of states of making sure to protect people or increase this ability to get the care that if we're staying healthier, then and ideally we're not getting sick care.
I just think there's real power, Natalie, in the problem of solving. I just want to get what I paid for with insurance and with healthcare, and that is a huge challenge. And if you can chip away at it, and again, I'd start with with drugs, but if you can get all that preventive stuff, that's great. But people just, there's a distortion field around not just pricing, but value and access that I think is go.
Mm-hmm. No, I'm sorry. I was just going to go back to the value-based care thing because I know we've been poking fun at you, Dave. But what we say is, we don't need to talk about value-based care to the everyday person. That is a tool to make sure that we're paying for, our opinion is, that's a tool to make sure we're paying for care that is high quality and people can access it and really transforming the healthcare system. But if we look at these 12 solutions from United Solutions of Care, the issues that people want, we cannot get there on a fee-for-service basis. So when we talk to people on the Hill or in the state capitals, we say, this is why you should care about this thing called value-based care. It is moving us away from the things people hate from the system and moving us towards a place where we can get people mental health, we can get people support as a caregiver, we can get people navigators or care extenders. People can understand when they go to the doctor, they can, then see the pharmacist who's on site as well as the PT or the OT. It really is creating that experience that people want.
So, John, I'm going to give you the last question in a minute, but I'm just going to put out a little communication suggestion there, which is I think the United States of Care should have like a national anthem, and it should include something about value-based care in it. And, all these free stuff.
What if we don't use that word, though? What if we don't use value-based care?
No, use some. I mean, you can use ramparts. You can say "or." There's all sorts of special words that you can use in an anthem. But that way, people can unite about it. They stand up at the end and they start cheering for it. I think that has the best chance. Of
great
being
idea,
successful.
David. Why don't you work on that in your free time? Yeah, exactly.
No problem,
so, Natalie,
John.
I guess the one thing I'd ask is, in the next 12 to 24 months, what's the one thing that you think the United States of Care can get done for the average healthcare consumer, the person who's trying to figure out how they're going to pay their bills, understand what they're going to get, and is worried about their healthcare? What can you do for that American patient?
Yeah, so I'm going to talk about the convergence of two things. One is the end of the public health. So I'm going to talk about access to care through virtual care.
I just asked for one. I just want one.
But they're coming together. They're coming together on the Hill. We have the end of the public health emergency coming at some point. We're not sure when, but a lot of the flexibilities that people have really benefited from of seeing a caregiver or a provider virtually. The Congress will need to act on that. And thankfully, this is a bipartisan area where both sides agree we need to act and make sure these flexibilities continue. And so we think in the next 6 months that will happen. At the same time as through this end of the year, this idea of mental health through virtual care, where we know it's such a need in this country that with these flexibilities and with Congress's focus, probably in a bipartisan way, to make sure that people can especially get mental health through a virtual setting is going to be really important.
Well, that's it for yet another edition of CareTalk. We've been talking today with Natalie Davis. She's the CEO and co-founder of the United States of Care, which you'll be able to hear about on an upcoming album. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. Natalie, thanks for joining us. And for our listeners and viewers, if you liked what you heard or you didn't, please subscribe.